Chapter 58, Concepts of Care for Clients with Problems of the Thyroid and Parathyroid Glands. The priority concept in this chapter is cellular regulation. The cellular regulation exemplar is hypothyroidism. The interrelated concept in this chapter is nutrition. Hyperthyroidism refers to excess secretion of thyroid hormone from the thyroid gland. This can be either temporary or permanent depending on the cause. Thyroid toxicosis refers to symptoms of hyperthyroidism. Excess thyroid hormone stimulates most body systems, causing hypermetabolism. This stimulates the heart, which increases rate and stroke volume, increases cardiac output, blood pressure, and blood flow. This also affects fat, protein, and glucose metabolism. Breakdown exceeds the buildup, resulting in a net loss of protein. Glucose tolerance is decreased, causing hyperglycemia, which will have an increase in appetite, but weight loss will still occur due to the hypermetabolism. Graves' disease is an autoimmune disorder. With Graves' disease, autoantibodies will attach to the thyroid-stimulating hormone receptors of the thyroid gland. This increases the number of glandular cells and thus enlarging the thyroid gland, and we see that with a goiter. With the endocrine system, particularly with the thyroid, hyper and hypothyroidism both, there's going to be a lot of signs and symptoms. There are a couple nice charts in your textbook, so make sure that you are referencing those for the signs and symptoms. One of the signs and symptoms we have here is exophthalmos, and we see that right here with the protrusion of the eyes. This used to be considered a permanent condition, but there are now newer medications that are being used to treat that condition. And here you have a picture of a goiter. But again, there's going to be a long list of clinical manifestations and signs and symptoms of hyperthyroidism. Just remember, everything is ramped up. Their metabolism is increased. Several lab tests here and diagnostics. And again, there's going to be a chart in your textbook that talks about this. So with hyperthyroidism, your T3 and your T4 are going to be elevated. Your TSH is going to be low to normal. And with the TSH itself, the thyroid stimulating hormone, a TSH level that's lower than normal indicates that there's usually more than enough thyroid hormone in the body, and this can indicate hyperthyroidism. For a thyroid scan, those are performed to evaluate the position and the size of the thyroid gland. The clients are given radioactive iodine by mouth, and then the uptake of the radioactive iodine is measured, and the normal uptake rate is going to be about 5 to 35%. Higher rates than that will suggest hyperthyroidism. Ultrasounds are performed to check the general size and position, as well as any nodules that might be present. And then ECG, remember they are ramped up. They have a hypermetabolism going on right here. So this may show SVT, AFib, or other dysrhythmias. For non-surgical management, monitoring for complications is really important. You want to make sure that you're taking an apical pulse, measuring their blood pressure and their temperature. And what you're looking for with that is a rapid increase in their vital signs, because that's going to indicate a possible thyroid storm. And a thyroid storm is a life-threatening event that's characterized by high fever, severe hypertension, and an increase in overall vitals. So you want to report the temperature even if it's a 1 degree difference. Early recognition and intervention is going to be key with that. You're going to reduce stimulation to reduce the risk of cardiac complications, keep the room quiet, promote rest, and postpone any non-essential care. And I know with nursing, we like to get all of our tasks done while we're in the room, so that way we're only going into the room once. With this, you may need to space things out to help reduce stress and stimulation. Promote comfort. You can do this by reducing the room temperature due to heat intolerance, possibly even a cold shower, have ice water available, and change the sheets if diaphoretic. Drug therapy is going to include anti-thyroid medications. One example is going to be Tapazole. Propothiazole is going to be another one, and those block thyroid hormone production. Iodine preparations, those are going to decrease overall blood flow through the thyroid gland, and reducing the blood flow is going to reduce the production of the thyroid hormones. Keep in mind that these type of medications, the anti-thyroid medications and the iodine preparations, they will not be effective immediately. They take some time to become therapeutic. So clients are not going to have relief from symptoms for about 2 weeks. So it's very important to note that, because they're going to need other medications such as beta blockers to help support them until their thyroid medicine works. So the beta blockers may be temporary. So beta blockers are going to be used as a supportive therapy to decrease palpitations, anxiety, and tachycardia, but they do not inhibit the thyroid production. So that may or may not be temporary. If indicated, or if the client doesn't respond to medical management, they may resort to surgical management with a total or subtotal thyroidectomy. So you're really monitoring these clients for any type of post-operative complications. Of course, respiratory is going to be huge, especially with a surgery in the neck. So that's going to be your number one, because ABCs, and hemorrhage is always going to be a risk with any type of surgery. So respiratory first and then hemorrhage. You also need to monitor them for hypocalcemia and tetany. Laryngeal nerve damage may be present depending on the extent of the surgery or any surgical complications. And of course, thyroid storm and crisis. And then these clients may have pre-existing conditions of eye and vision problems with the Graves' disease. So just keep this in mind. A lot of times I try to prep them beforehand and establish, even if they don't have laryngeal nerve damage, I try to prep them, because they're not going to want to talk, to have a communication plan in place before they have surgery. That's very important. With post-operative monitoring, you want to assess them for hoarseness or stridor. There could be pressure on the suture line from edema. Of course, hypocalcemia and tetany, so we're going to assess for tetany. So very important to go over signs and symptoms of hypocalcemia and tetany and your assessments for that. So you're going to be checking for Chvostics and Trousseau signs, and then of course thyroid storm. Moving on to hypothyroidism. So the pathology, the pathophysiology here is going to be that the thyroid cells do not produce sufficient amounts of thyroid hormones, and this results in a decrease of metabolic rate. So with hyperthyroidism, we had an increase, everything was amped up. With hypothyroidism, everything is slowed. So decreased metabolic rate, everything slows down. This is going to cause the hypothalamus and the anterior pituitary gland to release TSH, and that's going to be in an attempt to kickstart the thyroid gland. So increased activity is going to cause enlargement of the thyroid gland, possibly, not always, but they could have a goiter, and thyroid hormone production does not increase. So again, everything is slowed down, so cellular energy is decreased, and as a result, these clients experience weight gain. They're really fatigued, decreased pulse. They can also have a buildup of mucus and water inside the cells, causing cellular edema, and this is called myxedema. So with these clients, it's very important to tell them not to stop taking their medications, especially if they stop taking them suddenly, because that can result in a myxedema coma. And that is a rare but serious complication of untreated hypothyroidism. And it has a really high mortality rate, about 60%. With myxedema, these clients have an even further decrease in their metabolism, and this causes the heart to become very lazy. It becomes flabby, and the chamber size will increase. And as a result of that increase, they're going to have a decrease in cardiac output. So they're going to have decrease in perfusion, decrease in oxygen exchange, so gas exchange is going to be impaired, and this affects the vital organs in the brain, and it leads to organ failure. So pictured here is a client with myxedema. So we have some weight gain, and we see here that this individual's face is pretty swollen, including their tongue. So again, with hypothyroidism, same as hyperthyroidism, there's a chart in your book. So make sure that you're noting the differences between the two. So hyper, everything's ramped up. Hypo, everything is slowed down. So with hypothyroidism, you're going to have some physical assessment features. So edema around the face and eyes. They may have a blank expression, a thick tongue, slow muscle movements, delayed responses, slowed heart rate, decreased body temp. So it's going to be the opposite of hyperthyroidism, weight gain, and they may or may not have a goiter. A goiter itself is not an indicator of hyper or hypothyroidism, so they may or may not have that. Depression is a fairly common psychosocial symptom with them. They're going to have some mental slowness, and that can contribute to social isolation. And with their lab assessments, so they're going to have a low T3 and T4. The goal with these clients, you're going to improve gas exchange, prevent hypotension, so safety is going to be key here, support cognition, prevent myxedema coma, and then care coordination and transition management. Lots of teaching here. Lots of education. One more thing before I move on to the next slide. I just want to mention it's very important to note the causes of both hyper and hypothyroidism. I see a lot of people that will forget some of the causes of hypo, so that's going to be like damage to the thyroid gland, which includes radiation therapy. So lots of causes on there. Make sure that you're referencing those charts in your books for these. Thyroiditis, remember what itis stands for. So we have an inflammation. This is caused by a bacteria, and your symptoms are going to include pain, neck tenderness, malaise, fever, dysphagia, and that usually is going to resolve with antibiotic therapy. There's 3 different types here. So subacute, that is going to result from a viral infection after a cold or an upper respiratory infection. So symptoms are going to be chills, fever, dysphagia, muscle and joint pain. And this can also radiate to the ears, to the jaw, and the thyroid gland is going to feel hard and enlarged on palpation. Chronic, that is going to affect more women than men. That's an autoimmune disorder, and it's triggered by bacterial or viral infection, and this results in a self-attack or destruction of the thyroid glands. These clients are going to have low thyroid hormones and high TSH levels. For non-surgical management, we have drug therapy, and that's going to involve thyroid hormones for replacement to avoid any hypothyroidism and decrease TSH. And that's going to be with Synthroid or levothyroxine is the generic name for that. And of course, for surgical management, we can have a subtotal thyroidectomy. Thyroid cancer or cancer of the thyroid, there's going to be 4 types here. The papillary is going to be the most common type, and that's usually in younger women. It is slow growing and confined to the thyroid gland. Follicular, that's usually in older adults. That invades blood vessels and spreads to the lungs and the bones. It typically adheres to the trachea and the neck muscles and can cause laryngeal nerve involvement. So they will have a hoarse voice. And if you remember from when we were covering oncology, hoarseness is a sign and symptom of cancer. That's on that caution list. Medullary, that's going to be the most common in patients over 50, and that tumor secretes a variety of different hormones. The 4th type is going to be anaplastic, and that is a rapid growing tumor. It's very aggressive. It invades nearby tissues, and a lot of these patients have signs and symptoms of stridor, hoarseness, and dysphagia. Diagnostics for thyroid cancer are going to be ultrasound, CT, MRI, and PET scans. Thyroid globulin is going to be a lab test, and that will be elevated with thyroid cancer. Moving on to hyperparathyroidism. The parathyroids are going to maintain calcium and phosphorus balance. The parathyroid hormone PTH is going to act directly on the kidneys, causing increased reabsorption of calcium and increased phosphorus excretion. With hyperparathyroidism, you're going to have an excess amount of PTH that are going to increase bone reabsorption, so they're going to have a loss of calcium in the bones. This works by decreasing the osteoblasts, so that's going to be your bone production, and increasing the osteoclasts, which is the bone destruction. The release of calcium and phosphorus into the blood causes issues with bone density, anorexia, nausea, vomiting, weight loss, constipation. So lots of concerns here. And then the common cause of this is going to be a benign tumor of the parathyroid gland. Generally speaking, these can be surgically excised. And pharmacological management involves the use of diuretics, which are going to increase kidney secretion of calcium. We do that with furosemide, and also hydration with large amounts of saline to promote calcium excretion. And finally, hypoparathyroidism. Hypoparathyroidism is relatively rare. This is a disorder in which the parathyroid function is decreased, and this causes a lack of PTH, which results in hypocalcemia. Iatrogenic is going to be the most common, and that happens when all or part of the gland is removed during thyroid surgery. Idiopathic, that occurs spontaneously, and the cause of that is unknown, but most likely it is an autoimmune problem that is triggering that. Hypomagnesemia is going to be caused by hypoparathyroidism. So they're going to have low mag that suppresses PTH secretion and may interfere with the effects of PTH on the bone, which helps absorb calcium and vitamin D. And this concludes Chapter 58, Concepts of Care for Clients with Problems of the Thyroid and Parathyroid Glands.